Get test.
Good morning, everyone. It's my pleasure to extend a warm welcome to all of you on behalf of Hetero Healthcare. Today is a very special day as we are gathered here to get enriched with the advancement and recent updates on respiratory. This scientific summit is a testament to our spirit or our interest of knowing more on pulmonary science. Our scientific summit is named as Pulmogard. Pulmogard is, we are saying, as a frontier in pulmonary practice. I take pride to share with all the delegates and all of you that today's program, we are webcasting to 9 venues, including this, it will be 10 venues. So we are webcasting this program live, direct at Mumbai, Thane, another venue. Then we are webcasting at Pune, Nagpur, Indore, Surat, Hyderabad, Bangalore, Kolkata, and Ahmedabad. So all the delegates sitting at every venue, a warm welcome to all of you to this program. At this platform, I would like to share our corporate vision through a short film. So I'll request to start the corporate video.
At Hetero Healthcare, we are committed to improving lives. For over 30 years, our journey has been driven by one purpose: to enhance the quality of life through continuous innovation and advanced healthcare solutions. Presence in 126 plus countries with 36 state-of-the-art manufacturing facilities. Backed by a century's worth of experience, our team relentlessly pursues excellence. We aim to improve the people's quality of life with a wide product range encompassing multiple specialties and continuous research and development process with 1,000 plus top-notch scientists. We are more devoted to finding tomorrow's cure and the treatments for some of the most critical diseases. Over 2 decades of experience in developing APIs, among the largest manufacturers of ARV, APIs, and FDFCs in the world, is a testament to our commitment to high quality active pharmaceutical ingredients, pushing the boundaries of healthcare solutions. 21,000 employees working globally. In just few years, we introduced four groundbreaking 300 plus products, 314 formulation, distinction of bringing four biosimilar products to market within 5 years of initiation, Darbepoetin Alpha, Rituximab, Bevacizumab, Adalimumab, and 360-degree solution provider, revolutionizing treatment for millions. Our product range spans multiple specialties, from antiviral medicines to pioneering innovations like Fluvir. During COVID-19 pandemic, COVID-4, Remdesivir is our contribution to serve country and humanity, instrumental in the fight against COVID-19. Our achievements are recognized globally. One Express Pharma Excellence Award for COVID-19 drug launch, rewarding our contribution to provide COVID-4 Remdesivir access to more than 1 lakh patients. Largest manufacturer of HIV drugs, largest manufacturer of antiretroviral drugs, manufacturer of wide range of anti-cancer drugs. Our commitment to innovation goes beyond healthcare. In June 2023, our sister company Azista BST Aerospace proudly launched its first microsatellite, marking a new milestone. As doctors care for their patients, We Care for You initiative fosters a unique bond of trust, offering support not just through products. We Care for You is not just an initiative, but an emotion committed to you and your paramedical staff. Hetero Healthcare is committed to a healthier world for everyone.
Thank you for giving this opportunity to showcase our corporate vision. Trust me, this vision, this 2 minutes video is nothing. We are here to promote innovations, innovative product. So if you need any healthcare organization who can take you under your guidance, who can make innovative product, that is Hetero Healthcare today. So moving forward, I would like to call Dr. Khande Parkar sir, our medical advisor, to introduce our honorable moderator and speaker.
Thank you, Sumartini. Once again, a warm welcome to the Scientific Summit on Respiratory Advances and Diagnosis. Dear doctors, the objective of this summit is to provide healthcare professionals with a comprehensive understanding of novel diagnostic tools and innovative treatment modules. Today's summit will deal on asthma care. We look forward to your active participation and to the stimulating discussion that will follow the summit. Thank you for joining us once again for the Scientific Summit on Respiratory Advances and Diagnosis with asthma as today's focus. For today's meeting, we have a panel consisting of eminent chest physicians to give their insights in asthma. The moderator for today's session is Dr. Prahlad Prabhudesai, with the speaker Dr. Jay Bharat Mullarpatan. Dr. Prahlad Prabhudesai, sir, is MD DNB FCCP USA, consultant chest physician at Lilavati Hospital and Research Center, Mumbai. Dr. Prabhudesai is postgraduate teacher for DNB chest medicine and a course director for bronchoscopy, both basic and advanced at IMM AST. Director at Prabhakar Pulmonary Rehabilitation Center, which provides respiratory patients a health beyond medicine. As Dr. Prabhudesai has 62 publications, both in national and international journals, and respiratory medicine books, has contributed to books on community acquired medicine and edited book on controversies in COVID pandemic. Welcome, Dr. Prabhudesai. Morning, sir. sir. I request our AVP, Mr. Shailesh, to give bouquet too. The speaker for today's program is Dr. Jai Bharat Mular Patan. Sir is MBBS DNB Respiratory Medicine, Consultant of Respiratory Medicine, PD Hinduja Hospital, MRC, Mumbai. Special interest in procedures like pleural aspiration and bronchoscopy with biopsies. Dr. Mular Patan is Organizing Secretary for National Updates in Respiratory Medicine, hosted by Department of Respiratory Medicine at Hinduja Hospital, with 20 plus publication in books and oral presentation and poster presentation. Dr. Mular Patan is member and fellow of multiple respiratory societies like Indian Chest Society, European Respiratory Society, Fellowship of American College of Chest Physician, FCCP. Welcome, Dr. Mular Patan. I request sir to come on stage. And I request our Vice President, Veena Hatte, to give a bouquet. With this, I hand over the session to Dr. Prabhu Desai. Thank you, sir.
Thank you for the invitation and organizing this fantastic program on asthma and difficult asthma, the era of biologics. Uh, Jay is going to talk on, I don't want to waste time much on discussing about asthma. Dr. Jay is going to talk on bronchial asthma, the diagnosis and management and epidemiology. And I'm going to talk on how the era of biologics have come and how we really consider for biologics in treatment of severe asthma. So with this small introduction, first of all, I thank you all the audience and the people, doctors who are attending this meeting, and we welcome your questions and we have very good discussion on that. Thank you. Jay, can you just present your presentation?
The slides will come from.
Okay. So thank you for having me here. We'll be speaking on an important topic about difficult asthma.
Change the slide.
This one? This one?
That's forward and back.
Okay. So thank you for having me here. We'll be speaking on difficult to treat asthma today, and then Dr. Prabhu Desai will be focusing on biologicals. So the topic would be about overview of asthma, diagnosis, management, and then we will be having a case study as well. So, what is asthma? Basically, it is a chronic inflammation of the airways, and it's generally a reversible inflammation. It involves activation of the mast cells, eosinophils, lymphocytes, macrophages, neutrophils, and the epithelial cells. The main symptoms involve wheezing, shortness of breath, chest tightness, coughing, very often at night or early morning, and most of these episodes resolve either with treatment or spontaneously on their own. Sorry. And the characteristic pathology is widespread variable airflow obstruction, which is usually reversible spontaneously or with treatment. So, bronchial asthma can be classified into two major types based on the clinical presentation and Ig levels. One is the extrinsic or atopic asthma, where you're allergic to an external allergen, which is more present in children and young people. It is a intermittent pattern of asthma. You could have a positive skin test to the offending allergen. Serum Ig levels are very often elevated. There could be a family history of allergy, and generally there is no aspirin sensitivity. And in the intrinsic, which is the non-atopic asthma, usually not associated with allergens, could be seen more often in older adults, could have persistent symptoms. Usually a skin test is negative. Ig levels may be normal or sometimes elevated. Family history is uncommon, but in a small subset, you could have aspirin sensitivity. So, phenotype versus endotype, which is usual, which is quite useful in uh, having a specific treatment for your patients. So, sorry. Okay. Yeah, so you have either a T2 high or T2 low asthma, which is what is the basic classification we go down these route these days for, especially for severe asthma, because that will guide us whether we can use our anti-IL-5s and anti-Ig monoclonal antibodies. So T2 high are generally either atopic, late onset, or aspirin exacerbated respiratory disease, and characteristics with atopic are generally well-defined early onset, steroid sensitive with preserved lung function. There is allergic sensitization, and there could be blood or sputum eosinophilia, serum specific allergen Ig, high pheno and high total Ig. Late onset will have concomitant chronic rhinosinusitis with nasal polyposis. They quite often steroid refractory and would have severe frequent exacerbations. Molecular mechanism postulated could be a Staph aureus enterotoxin, and there would be blood and eosinophil, blood and sputum eosinophilia with a high FeNO. Ig could be normal in these cases. And AERD, where again it's adult onset, severe frequent exacerbation. There is dysregulated A metabolism, and again high eosinophilia and urinary leukotriene E4. In the non-T2, usually it's non-atopic, where it could be granulocytic with variable course, usually seen with NLRP3 and altered microRNA expression and TH17. You could have induced BAL neutrophilia and MP9. Smokers, again older adults with frequent exacerbations and lower lung functions due to oxidative stress, and again high neutrophil count. Obesity related, more in females, severe symptoms, preserved lung function. Again, the mechanism is oxidative stress guided by neutrophils and high serum IL-6. And in elderly, where you have a steroid resistant asthma of over 50 years age, where you have immunosenescence with Th1 and Th17 inflammation, and again high sputum neutrophil count. So you can see T2 high is either high IgE or high eosinophil guided asthma, generally better response to treatment, and T2 low is generally neutrophil guided treatment, neutrophil induced asthma, and generally it responds poorer and is more refractory to our standard treatment with steroids and etc. So pathogenesis of asthma, basically we know, especially in allergic asthma, we have the immediate phase and the late phase reactions. Immediate phase occurs within the first half an hour, and late phase within 4 to 6 hours. Immediate phase we know is rapid onset, peaks quickly, and resolves over 24 hours. It involves mast cell degranulation, releases histamine, leukotrienes, and bronchoconstriction. Th2 activation, which is IL4, IL5, and IL13. Late phase is bronchoconstriction lasting up to 24 hours, hyperresponsiveness up to 2 weeks, and Th2 cells and eosinophils progressively increase the inflammation. Key mediators in immediate phase is IL5, GM-CSF, IL4, IL13, and allergen-specific IgE. They cause attraction of eosinophils, promote IgE production, and lead to bronchial hyper responsiveness and airway damage. And allergen-specific IgE triggers mast cell degranulation and releasing mediators that cause bronchospasm, inflammation, and these later set up the delayed phase. And key mediators of an airway remodeling of late phase is induced by eosinophils, which release cysteine leukotrienes and toxic proteins. And other mediators includes adenosine, nitric oxide, and neuropeptides. So natural history of asthma. So prevalence is 1 in 7 to 12 individuals. It is in adolescence. Risk factors for high morbidity and mortality would include low socio-economic status, poor follow-up care and adherence, lack of a personalized action plan, and tobacco smoking. Asthma progression. So remission predictors would be mild asthma, low inflammation, no allergy, and male gender. And persistence and severity predictors include family history, high type 2 inflammation, atopy, low lung function, smoking, and severe asthma. And gender differences post puberty would are shown by shift from male to female predominance. Females at more at risk of severe asthma due to factors like genetics, hormones, and lung growth. So coming to diagnosis of asthma. So first we need to look at is it truly asthma? So you need to know what are the other things which could present similar to asthma as a differential diagnosis of asthma. So you should always be on the lookout for bronchiectasis, gastroesophageal reflux disease, which is very often can be labeled as asthma or very often even present along with asthma. Cardiac disease, pulmonary edema very often comes up with wheezing, and that could be sometimes mistaken as asthma. COPD, especially if the patient is smoker, so you need to find out whether this is an asthmatic who's smoking or someone who has developed COPD. Obesity is a risk factor for asthma, but also can lead to refractory asthma. Post-nasal drip, especially in patients with chronic rhinitis, will give you nighttime symptoms of cough. Cough induced by ACE inhibitors, very important cause. So a drug history in patients, very important. Tracheobronchomalacia, especially in the elderly. Vocal cord dysfunction, especially people with normal lung functions, and young females, especially if they are anxious, look for vocal cord dysfunction. And deconditioning. So if patients, especially people with sedentary jobs, if they're not very mobile, not used to exercise, if they come up with breathlessness after say a trek or something, it could just be deconditioning and body not used to the kind of exercise rather than actual asthma or any lung issue. So thorough history and physical examination is important. So dyspnea can be seen in COPD, obesity, cardiac disease, and deconditioning. Cough could also be seen in inducible laryngeal obstruction, that is vocal cord dysfunction, upper airway cough syndrome, that is a postnasal drip, gastroesophageal reflux, ACE inhibitors, and bronchiectasis. And wheeze very often seen in vocal cord dysfunction, tracheobronchio, malacia, COPD, and very rarely in obesity. So confirmation of diagnosis, almost a quarter to half patients can be initially assumed to be severe asthma when there could be something else. Look at spirometry. You need to perform before and after bronchodilator use, assess baseline lung function, and seek evidence of variable expiratory airflow limitation. If initial bronchodilator responsiveness is negative, that is, the reversibility is less than 200 ml and 12% in FEV1, repeat testing after withholding bronchodilators or when symptomatic. Uh, Sometimes this might not always be easy, so it could be important to have a peak flow meter with the patient, where if he gets a sudden attack, they should check their peak flow meters, and if there is a 20 to 30% drop in the peak expiratory flow rate from the baseline, that could probably show variable airflow obstruction and confirm a diagnosis of asthma. And consider adjusting controller treatments before further investigations. So full flow volume curve, check for upper airway obstruction, especially if it's a vocal cord dysfunction or vocal cord paralysis. You would get a box pattern on the PFT. Peak flow meter, as we mentioned, provide for assessing variability if spirometry is normal or unavailable, especially if there are only nighttime symptoms. Bronchial provocation testing. So if a patient is having a normal spirometry but persistent symptoms, you could go for bronchial challenge with either methacholine or histamine. For that, of course, you need to withhold SABAs, that is your salbutamol, for at least 6 hours, and LABAs, that is salmeterol or formoterol, for at least 2 days, depending on the duration of action. Factors contributing to symptoms, exacerbation, and poor quality of life. So look at inhaler technique. So once you have diagnosed asthma, 80% of your patients are very likely to either misuse or not use their inhalers properly. So always check their inhaler technique when they visit you at your clinic. Make sure they have the correct treatment inhaler technique, inhaler for that patient, whether they need a spacer, whether it's a direct inhaler, do they need a DPI, or sometimes if it's a very elderly patient or someone with other comorbidities who cannot take an inhaler, maybe might need to be shifted to a nebulizer. Adherence, we've seen that suboptimal adherence in about 75% of patients, and very often people feel that if they're feeling better, they don't need to take their inhalers. So education is very important. Cost, side effects are other things, especially, if people don't gargle after using the inhalers, they could get hoarseness of voice or oral thrush. Comorbidities, very important. Review for anxiety, depression, obesity, GERD, OSA, or cardiac disease, which could be either your differentials or could coexist with asthma. Modify risk factors, always insist on smoking cessation. Look for any avoidable allergens like, say, pets at home, carpets, birds, etc. Air pollution, overuse of SABAs without ICS. Psychosocial factors, as we've mentioned, anxiety, depression. Sometimes having a joint consult with a psychologist or a psychiatrist is very important. And medication side effects, look at systemic and local effects of your oral corticosteroids or inhaled corticosteroids, and monitor for drug interactions, especially if you're using things like the theophylline. So management of asthma. So key objectives is, one is symptomatic relief during an acute attack, prevention of future attacks, and maintenance of normal pulmonary function and functionality between attacks. So what are the bronchodilators in asthma management? So you have the most effective ones are, of course, your beta adrenergic drugs, that the beta 2 agonists, which could be short acting. Most commonly used is salbutamol, and they are used as rescue drugs for acute attacks. Onset within 1 to 5 minutes, so they give you immediate relief, and duration of action about 4 to 6 hours. It can be given 100 to 200 microgram inhaled. We avoid orally nowadays because there could be cardiac side effects. It is safe in pregnancy, and long acting could be salmeterol and formoterol. Of course, you have the ultra labas now, let's say indacaterol and vilanterol, which are also available. Slow onset, they last for about 12 hours. Of course, formoterol has a quick onset of action as well. Used for chronic management, doses would be 50 micrograms of salmeterol or 12 micrograms of formoterol twice daily, and must be used with corticosteroids to avoid risk of exacerbations. Never use them alone. Anticholinergics could be ipratropium, which is short acting, or tiotropium, which is a long acting, or other long actings which are such as lumeclidinum or glycopyridinum, which are also available. Methylxanthines such as theophylline and aminophylline. It is non-selective phosphodiesterase inhibitors used in severe refractory asthma, but it has a narrow therapeutic range and should be used with caution, especially in the elderly. Anti-inflammatory, this is the cornerstone of management of asthma from mild to severe asthma. So inhaled corticosteroid would be present in almost all your prescriptions. It is used for managing asthma in all ages, reduce airway inflammation, improve lung function and prevent exacerbations, modulate gene transcription, reducing pro-inflammatory proteins and increasing anti-inflammatory ones, and mild side effects due to oropharyngeal candidiasis, which is minimized by using spacers, as well as ensuring that your patient gargles after each dose. Leukotriene modifiers, this prevent bronchoconstriction and mucus hypersecretion and inflammations from leukotrienes. It is especially effective against exercise-induced asthma, as also in aspirin exacerbated respiratory disease. Mast cell stabilizers such as cromolyn and nedocoromyl, not very frequently available in India. It is less potent and it is usually used in exercise-induced asthma. And biologicals, of which the oldest one is omalizumab, which is an anti-IgE1. And apart from that, we have anti-IL-5 and anti-IL-4 antibodies, which of course Dr. Prabhu Desai will be speaking about. So evolving asthma care. So we have the 2024 GINA guidelines, and we need to just see the difference between the previous guidelines up to 23 and GINA. So in the previous guidelines, relied on SABA for symptom relief in mild asthma, while in GINA 24, they've discouraged SABA monotherapy and emphasis on either ICS formoterol or ICS salbutamol, which combination. So use ICS along with your reliever bronchodilator and not using bronchodilators alone. That is shown to reduce further attacks. Personalized medicine, encourage personalized medicine based on biomarkers, asthma phenotypes, and patient profiles. ICS was first only for persistent symptoms in mild asthma. Now it has been used for even intermittent symptoms in mild asthma. Severe asthma has shown an emphasized stepwise escalation of ICS doses, and now they have looked at biological for targeting specific pathways and risk reduction. Stress on preventing exacerbation and long-term risks have been focused upon in the new GINA guidelines. So GINA 2024 guidelines on optimizing management. One is self-management education, ensure patient knowledge on personalized asthma action plan, refer to an asthma educator if available, optimize inhaled medications, confirm inhaler suitability and check in correct technique based on teach back method. You need the patient to in fact take a dose in front of you so that you are confident that they're taking it properly. Address suboptimal adherence. Consider ICS formoterol for maintenance and reliever therapy to reduce exacerbation risk. Non-pharmacological add-ons encourage smoking cessation, physical exercise, healthy diet, weight loss, mucus clearance and vaccination, manage comorbidities and avoid asthma worsening medications, such as say beta blockers and additional therapies. Consider adding LABA, LAMA or leukotriene receptor antagonists to medium high dose ICS and trial high dose ICS LABA if not already in use. So next steps should be review after 3 to 6 months, schedule based on clinical urgency and treatment changes, assess response and address concerns, symptom control, exacerbations and medication side effects, reassess lung function, inhaler technique and adherence and patient satisfaction and concerns. If the asthma is still uncontrolled, confirm severe asthma and refer to a specialist if a severe asthma clinic is not already done. And if if asthma is well controlled, consider step down treatment and start by reducing your oral corticosteroids and then can reduce ICS dose to a minimum, but do not stop your ICS. And if the asthma becomes uncontrolled again after stepping down, confirm your severe asthma, restore your previous dose and refer to a specialist. Referral considerations would be to difficulty in confirming asthma diagnosis, frequent urgent healthcare utilizations, especially frequent exacerbations and frequent hospitalizations, requirement for frequent or maintenance oral corticosteroids, suspected occupational asthma, presence of food allergy of anaphylaxis, symptoms suggestive of infective or cardiac cause, symptoms suggestive of complications such as bronchiectasis, and patients with multimorbidity such as cardiac disease, GERD, obstructive sleep apnea, etc. So we'll just go through a case study just to, it's like a summary of what we've discussed. So the case is about acute onset severe breathlessness, wheezing and chest tightness, not relieved by usual medications in a 55-year-old male who's been diagnosed as asthma for 15 years. Presentation was a three-day worsening of dyspnea and chest tightness. Despite a use of rescue inhaler salbutamol, symptoms persisted, leading to a peak flow measurement of 35% of the predicted value, which put him in a severe exacerbation group. Of course, nowadays we would not prefer salbutamol as a reliever. We would prefer formoterol with ICS. Asthma history was diagnosed at the age of 30, poor control with frequent exacerbations requiring hospitalization, claims to be regular medication with medium dose ICS with a long acting beta agonist. Comorbidities, patient is obese with a BMI of 32, also has allergic rhinitis and hypertension and is a non-smoker. So medication history, patient on budesonide formoterol of 160, 4.5 per actuation, 2 puffs twice daily, Montelukast 10 milligrams, salbutamol as needed, and nasal corticosteroid fluticasone, 2 sprays per nostril once daily, and also on lisinopril, which is an ACE inhibitor, once daily. Examination tachypneic with tachycardia, hypoxemia with saturation of 88%, blood pressure 150/90, use of accessory muscles suggestive of respiratory distress with diminished breath sounds and wheezing, no cyanosis, eosinophilia in the blood count when a peak expiratory flow rate of 150, which was quite reduced, mild hypercapnia with hypoxemia and respiratory acidosis on the ABG. X-ray showing hyperinflated lungs, thankfully no pneumothorax or pneumonia. Clinical so criteria supporting diagnosis would be history of poorly controlled asthma, acute symptoms, unresponsive to usual therapy, objective findings of respiratory distress such as increased use of accessory muscles, wheezing and reduced peak expiratory flow rate, and blood gas abnormalities. Patient was immediately started on high flow oxygen to maintain his saturations above 92%. Nebulized bronchodilators with a combination of salbutamol and ipratropium every 20 minutes. Systemic corticosteroids as methylprednisolone 1 milligram per kg initiated to reduce inflammation, and magnesium sulfate 2 grams is administered for his bronchodilator effect in severe exacerbations. So 1 hour after treatment, patient improved with saturations to 92% on oxygen. PCO2 improved to 42. and PaO2 was 72. Repeat peak flow showing partial improvement from 150 to 190. Given the partial response, nebulization was continued and additional dose of IV corticosteroids was given. Thiophanol was considered, infusion was considered as a second line treatment due to suboptimal response, and monitored closely for signs of fatigue, hypercapnia, and respiratory failure. Given the history of poor control despite maximal inhaled therapy, patient was identified later as a candidate for biological therapy anti-IL-5, and after stabilization, biological therapy was initiated to address severe eosinophilic asthma in line with the GINA recommendations. Patient was gradually weaned off nebulized bronchodilators and transitioned to a dry powder inhaler with high dose ICS-LABA, short course of oral steroid prescribed for 5 days, and education on proper inhaler technique was reinforced. And discharge plan include regular follow-up for biological therapy administration. Mepolizumab, as we know, is given once every 4 weeks. Monitoring peak flow at home, continuation of maintenance therapy of ICS-LABA and Montelukast, and clear strategy for recognizing early signs of exacerbation and appropriate rescue medication use. So follow-up, 1 month follow-up, significant improvement with reduced use of rescue medication, peak flow improvements to 80% of predictive values, no further exacerbation on mepolizumab therapy and a high ICS LABA regimen, marked improvement in asthma control as evidenced by an improved ACT score. So we can see the tachypnea and heart rate have settled, oxygen is better, peak flow has improved, arterial blood gas has almost normalized, chest x-ray is normal, eosinophil count has come down to 2%, ACT has improved from 8 to 21, and rescue inhaler, which was more than 4 times daily, has now reduced to just 1 to 2 times per week. So clinical insights would be managing severe acute asthma in a patient with multiple exacerbations and poor control can be challenging. The GINA 2024 guidelines do emphasize a personalized approach to management, particularly for patients with severe asthma who may benefit from biological therapies targeting specific inflammatory pathways such as IL-5 in eosinophilic asthma, early recognition of a poor response to standard therapy, and timely escalation of care, including the use of systemic corticosteroids, magnesium sulfates, and biologicals, can significantly improve outcomes in such challenging cases. Thank you.
Hello. 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 Thank you, Jay, for a very detailed information on bronchial asthma, severe asthma, and a case, and how you lead to a biologic. So my talk is regarding some aspects which are covered by Dr. Jay. Probably I may little enforce them. And let's see how the era of treatment of bronchial asthma is changing. Can I have my slide? So you are all aware that bronchial asthma is not a simple disease to it has been already introduced about the bronchial asthma. This is a nutshell about, say, asthma is a complex disease because it has got a huge spectrum. It's an inflammatory disease. It's a hyper responsiveness to airways, to variable hyper responsiveness. You may have response to bronchodilators, you may not have response. Then symptoms are also variable. They are not so easy, coming from tightness in the chest to actually wheezing and cough. You may have only cough also, and the airflow limitation that is also variable. But it is very important to understand the disease is heterogeneous. So what is the we mean by heterogeneous? It has got heterogeneity in various aspects. From symptoms point of view, just now I said, exacerbations, allergies, variable, lung functions are also variable. Okay, it may be normal to severe, reversible to non-reversible,
and even treatment response. You may not respond to a best possible line of therapy also. And all this is airway inflammation. Again, Dr. J.S. very nicely told about Th2, high Th2 and low T2 high and T2 low. So this is inflammatory phenotypes. This is also variable. And finally, what it leads to a type of endotype, that is the mechanism of bronchial asthma, which leads to this heterogeneity. And that's why it is not very easy to say that I can manage my asthma patient extremely well. No, you may have difficulties in treating asthma despite of a very good knowledge. And he has covered the incidence prevalence is very high. What is very important to know in our country is that global burden of disease reported in India contributes to around 46% of our global asthma deaths comes from India. So though asthma is prevalent all over the world, though our population is also high, so obviously we have more asthma patients, but what is worst is that we have mortality rate of asthma is high. And the reason for this is lack of inhaled corticosteroid use. We are all from pediatric patients to even adults patient, people are scared to use inhaled steroids, okay, and this is a problem. And we overuse bronchodilators, and this is what Gina doesn't want, because asthma has to be controlled, then inhaled corticosteroid has to go, and we have to find out if people are very happy to use bronchodilator because they get immediate response. Why not have a combination of bronchodilator and steroid compulsory available together, so that they use whenever bronchodilator, inhaled steroid also will go, and overuse of bronchodilator will be avoided, and this will lead to a lesser amount of deaths. So I'm not going to detail about the difficult asthma, what Dr. Jay has told, but it is varying from 6.9 to 10%, and say the prevalence, sometimes the difficult asthma is even a little high. Approximately, say you can say that the approximately around 6.9% of the children and 10% of adult patients have severe asthma, although large prevalence range comes from 1.8 to 38% overall reported of severe asthma. Okay. This is the overall asthma control, if you see. Okay, despite being adequately treated, okay, almost more than 40% of asthma remains uncontrolled. Okay, this is not just Indian figures, it's all over the world. Okay, and this is much more concerned. So most of our patients, despite of being adherent to the therapy, despite of being, we told them to take the inhaler regularly, the correct techniques and proper combinations, still you have almost 45% uncontrolled asthma, and that uncontrolled asthma leads to severe asthma. And why severe asthma is important? Because it significantly have a higher morbidity, mortality also, and utilization of healthcare facilities are much higher. This is very important in country like Western countries, because they have limitations, they have all other issues, and they are much more bothered about healthcare utilization. Okay, in our country also it is equally important, and we have to give importance to that, so that our asthma patient should not contribute much in the hospital, the admissions and casualty, etc., and all that. That burden also we have to reduce, and the disease control has to be there. And for that, what is very important, that we have to use combination of inhaled corticosteroids. Before we label them as severe asthma, they should be given a proper dose of inhaled steroids with a bronchodilator. If required, a second controller, sometime corticosteroids if required. But if the corticosteroid use is very high, okay, then the complications do happen to the patient, which we do not give importance. The corticosteroids, even 3, 4 times in a year, if you are using a pulse therapy for 5 to 6 days, they still contribute the complication. And if you are using it much more higher than that, obviously the complication rates are very high. And this is an impact of severe asthma. the mortality, significant socio-economic burden, poor quality life, hospitalization, exercise, and I will add in that the side effects of medications also. That's very important. So this is our overall era of treatment. If you see, the asthma before 1985 was just bronchospasm and relieving bronchospasm. This is the treatment of asthma when I started my MD in respiratory medicine somewhere in 84, 85. And then came the era of anti-inflammatory drugs. Steroids came over there. Inhaled steroids, higher dose steroid, various types of steroids were developed. Various types of bronchodilators came into the picture. Cromolins have come as the anti-inflammatory there. And then as the era passes now to say around 2017 onwards, 10 onwards, the era is of phenotyping and endotyping asthma and the biologics era. So this is how the overall development, and these are all biologics which are developed from 2003. The omalizumab, which is almost 20 years or 21 years of experience we have, that it is the drug which has been used correctly, gives a lot of benefit. And the drug later on came mepolizumab, reslizumab, benralizumab, dupilumab, and now the tezepelumab. So these are all biologics which are coming into the picture. We have to understand when to use which biologics. So this is something which is really the respiratory physician should have a knowledge, and they should constantly be in touch with these endotypes of bronchial asthma, the mechanism of bronchial asthma. And see, this is another important slide showing the research in respiratory medicine, especially in asthma. In before 94, if you see, there were almost, this is almost 4,848,000 studies were done in asthma before 1984. Only you can say that it is predominantly on bronchodilator and anti-inflammatory. And the biologics blue line, if you see, they are much, much lesser. And see that now in 2014 to 24, the number of studies, if you consider, the biologics were significantly high compared to the bronchodilator. So overall research is towards biologics. Maybe more and more biologics are going to come once we understand the endotypes or mechanism of severe asthma. Or these biologics are now we are using it because of only for severe asthma. But who knows that the research is going in such a way that probably biologics may be a part on not only in severe asthma but moderate asthmas or asthma which is not really severe, but patient which has got a poor quality of life, patient who requires lung function dropping, patients who are requiring much more higher dose of inhaled steroid. So these patients currently they are not in the guidelines for biologics, but may come. So overall research is going from bronchodilators to anti-inflammatory to phenotyping the asthma to more on endotyping asthma and use of biologics. So this is how so I can say that this is an era of biologics in bronchial asthma, and it is going to evolve much more faster. This was the mechanism which was earlier, we used to say that just antigen expression to antigen predisposing cell leading into IgE from Th2 cell to ordering B cells and plasma cell to produce more IgE, and this IgE is to get attached to the mast cell and eosinophils, and then the antigens get attached to this IgE, leading into histamine, leukotriene, prostaglandin, cytokines, and basic protein enzyme leading to allergic. This was the mechanism when I did my MD respiratory medicine, and we were all talking about how to prevent this, okay, by cromolins and other medicines. So this was the mechanism, and today the mechanism is much more complex. Okay, see here that antigen expression leads to IgE is one of the only one important you can say that factor in producing allergic asthma. But then the various interleukins have come, IL-5, then there's IL-4R receptors have been developed, and then IL-4 and you can say that and also the anti-TSLP. So these are all various aspects have come in bronchial asthma pathogenesis, and that had led to a development of biologics so that we can go beyond just bronchodilators and anti-inflammatory drugs. So these are all T2 and non-T2. Dr. Jay has told very clearly. But let's see the phenotypes. T2 will have atopic, late onset, and aspirin-induced respiratory disease, or you can say exacerbation due to aspirin. Okay, this comes into T2 high. The characteristics, what I would like to observe that these are all well defined and they're all steroid sensitive. So if your asthma responds very well to oral corticosteroids, and after stopping steroids, patient remain asymptomatic a very prolonged period of time, okay, that basically is a T2. Very clearly you can understand by your practice and identify your patient to how they are. And if they become refractory to steroids, means what? They respond to steroid, but you have to use very frequently steroid, or you have to maintain some dose of steroid. So these are not basically, you can say that they are all, maybe you have to think about something else mechanism going on, okay? And they're all adult onset, T2 high. Non-T2, okay, the non-atopics, they are smokers, they are having comorbidities, sometimes they are elderlies, and their onset is little different. They are neutrophilic, their sputum may not see eosinophils, and they are more in the female, and this is how you can say the non-T2. And this classification is important because there are biomarkers for each subtypes, okay? Say for example, T2 high, the sputum eosinophil count will be more than 3. We don't do sputum eosinophil count, but we do blood eosinophil count. Now they are matched. Though the sputum eosinophil is very specific, blood eosinophilic is very also equally good, and more than 300 absolute eosinophil count is considered as a marker for biomarker for T2 high. Remember, most of our patient doctors think that India to eosinophilia is very common because of parasitic infection. Yes, we don't have a huge data on that, but whatever we understood, this is not true. Okay, we still can consider more than 300 as a marker for uncontrolled asthma. Yes, we have to see that patient is off steroids when we say about eosinophil count 3%. So what I do is that we take out all their CVC report done in the past and see what is happening to them. Select the eosinophil count when they are not on steroids and consider your patient whether he is eosinophilic, or you stop the steroid for some time and give. And if patient you cannot make off steroids, then you have a version that even the steroid little lower side between 150 to 300 also we can consider as a marker. You have serum IgE level marker, your nitric or FeNO is now available in every hospital and even a small respiratory physician's clinic, and that can guide you regarding some of the biomarkers. Periostine, etc. we don't do, and currently no cheaper markers are available to measure IL-4, IL-5, etc. and all that, though they are actually a biomarkers, but they are not practical to do. So low T2 low is sputum neutrophilia and these other markers, potential biomarkers, not possible and not available. So this is GINA 2014 asthma management, bronchodilators. Recommended to use oral corticosteroid if it is not possible to treat asthma exacerbation or treat asthma. So this was the recommendation 2014. 2019 introduced other biologics and advisory on use of oral corticosteroids. So changing stage 4, stage 5, see, asthma guidelines, GINA, changing from only steroids now at steroids as a advisory, but use biologics. And 2024, predominantly biologics in severe asthma. Dr. Jay has told you what is severe asthma. So now we talk about biologics in severe, and steroid remains the last aspect. Why? Because it has got a very high risk of complication. So I also in the beginning say what steroid complication, but when I see them in the later part of their life, as they live long, they all die because of the fractures. They all die because of the uncontrolled diabetes and bacterial infection. They all poor quality life because of myopathies and chronic pain. Besides, obviously, the effect on the eyes, glaucoma, and they remain silent. Nobody bothers about that. But remember, these are all things which are there and finally leads to a poor quality life, which is more important in managing asthma. And this currently the US FDA has approved almost 6 important biologics: omalizumab, mepolizumab, benralizumab, reslizumab, dupilumab, and tazilumab, that is anti-TSLP. So these are all various biologics, and I just want to tell you about in depth about these biologics. Omalizumab is Xolair. It is action is anti-Ig. It can be used more than 6 years, and it is in the moderate to severe persistent asthma. The Ig level should be between 30 to 1,300 for between the younger age group, 30 to 700 in age more than 12. European guidelines have little extended to around 1,005. Okay, allergic rhinitis, chronic rhinosinusitis, nasal polyposis is an indication when this is associated with asthma, and dosages which are, you all know that depend upon Ig levels and body weight, and it can be calculated and given every week, 2 weekly to every monthly, depend upon the required. Subcutaneous injections. Similarly, mepolizumab, Dr. Jay has given a case. Here is anti-IL-5. It can be used more than 6 years. Severe eosinophilic suggested when absolute eosinophil count is more than 300 or between 150 to say 300. Chronic rhinosinusitis and polyposis, if it is there, is useful. It is again a subcutaneous injection of 140 to 100 milligram and mcg, I think, and it can be given subcutaneously. Reslizumab is another anti-IL-5 which is not available in our country, more than 18 years. Severe eosinophilia and suggested when eosinophil count is more than 400, and it is a drug which is given intravenously. That's the difference between the mepolizumab and this. Benzralizumab available in India, more than 12 years old patient we can use. Anti-IL-5 receptor antibody used when severe asthma suggested when eosinophil count is more than 300. Again, it can be used for chronic rhinosinusitis and polyposis. Injections is given every monthly 3 injections, then every 2 monthly we can give, and it is even subcutaneously. Dupilumab, studies are there going on. It is anti-IL-4 receptor, very interesting. This biologic have a still role to play in many of our patients. More than 6 years, severe eosinophilic asthma suggested. Now here, the FeNO becomes very important, and it is a good biomarker for this, especially when FeNO is high, then they respond very well. Obviously, eosinophil count also is an important marker, and it is used good with the atopic dermatitis associated with asthma or chronic rhinosinusitis. It is given subcutaneously, 200 to 300 milligram dose, and every 2 weekly can be given 2 weekly after the looking the dose. Okay, and tezepelumab, anti-TSLP. This is the thing which we have to watch now, because it will be available in our country probably in 2025 somewhere, maybe take 1 year, but it is used for uncontrolled asthma, and it is subcutaneous injection, 210 milligram. It has got an action at both TH2 and TH1. That's the beauty of this, and probably we have to watch how it goes. Studies come. There are studies. It has been approved by US FDA for using asthma, for even lesser eosinophil count, and patient who are neutrophilic asthma also we can use this. So both T2 high and T1. So this is a drug which has got going to change the management of difficult asthma. So these are available in our country. This is available in our country. This is available in our country. Okay. So let's see what has happened. Now we are saying about biologics. What the is there any meta-analysis which showing biologics are really effective? Beautiful article in European Respiratory Review in 2024. This is very current, done by Christos et al. And see what they have done here is that it is comprehensive meta-analysis. Okay, 48 studies where they have taken a total 16,350 patients, randomized control trials involving licensed biologics until 31st January 2023, aim to assess the efficacy and safety of licensed 6 biological agents. See, there is no comparable data between omalizumab versus benralizumab, omalizumab versus mepolizumab. You will see this all overlap is there, or even a biomarker. There is no fixed biomarkers which can say that yes, this is a biomarker. This is. So there is a lot of overlap. So a lot of experience is also required. A lot of practice is also required. What you do, your previous experience also. That's why asthma's clinic give you much better idea about using biologics. But once you have a point biologic marker available, then most of our respiratory physician can consider this is probably a best line of therapy. But here, what meta-analysis shows is also very important for our knowledge point of view. They're trying to assess 6 biologics. What is happening? What are the studies? And see how they have studied. I can't see, but there are more than 3,666 total studies were included till 2023 on various search index, Medline and other thing. And finally, they slowly removed the studies which were having review articles, double studies, duplication, language issues, etc. and all that. And finally, from 3,666 some studies, they have come down to around 48 studies, okay, which included around 16,600, 350 patients, okay. Very beautifully done, okay. And what is their outcomes? Primary endpoint was to find out exacerbations. How many, whether these biologics can prevent exacerbation, which we are all most worried about, or asthma getting exacerbated despite of proper treatment means hospitalized, steroids, etc. So they found out how many exacerbation annual rate. And secondary endpoint, hospitalization for asthma exacerbation, lung function they also included, oral corticosteroid use and sparing effect. If patient is on steroid, can we remove the steroids? Prednisolone dose, how much percent we can reduce the steroid dose? Asthma control questionnaires were put, asthma control test was applied, asthma symptom score was put in these, and asthma quality life questions. Everything studied completely thoroughly about asthma, from symptoms to quality life, and the safety of medicines. That also were included. So these are very good this thing, and they have studied subgroup defined high and low eosinophil, more than 300 eosinophil count, less than 300 eosinophil. What is the difference in biologics? Exhaled nitric oxide more than 25, less than 25. What is the difference? Lung function, asthma, these are all points they have taken. They also included if the eosinophil count is less than 150 and more than between 150 to 300 and more than 300. So what is the difference? They also subgroups from FeNO less than 25, 25 to 49, more than 50. So very comprehensive workup they have done, subgroups they have defined, and results was what? Very interesting. It reduced exacerbation overall, concluding all biology. 44% more appeared patients with a high blood eosinophil count. The 62% reduction, FeNO up to 67. The exacerbation reduced overall by almost 44%. Okay, and higher the count with the higher eosinophil count, and the high FeNO reduction was up to 62 and 67%. Reduce the risk of hospitalization by 60%. Okay, the single exacerbation reduction is mainly driven by studies on tezepelumab, anti-TSLP, and to lesser extent by dupilumab. So this has given a little edge over the other, but overall everything was together. All biologics were useful in reducing the exacerbation and reducing the hospitalization. Significant oral corticosteroid sparing effect was increasingly probably significant amount of OC was also sparing effect was seen in all biologics, increasing the probability of reduction to less than 5 milligram. Prednisolone dose was 74%. Means patient who was on oral steroid higher dose, almost 74% of the patient they could reduce the steroid dose to less than 5 milligram. It's a great achievement, and probability of oral corticosteroid discontinuation was seen in 63%. Reducing the oral corticosteroid dose by 35%. So this is a overall result of the study on meta-analysis, and this evidence from meta-analysis. This is a beautiful graph, shows you can see the line. These are all various biologics on the left hand side: anti-IgG3, anti-IL4, IL5 receptor, anti-IL4A, anti-TSLP, all if you see. And if you see the line over there, okay, here, this is a line which shows favorable results versus favors control. So when they are control versus favorable, control means they are not the placebo, the control is the patient who are taking other bronchodilators, steroids, standard line of therapy. And you find every biologics has got favorable results compared to the controls, okay. Similarly, mean FEV1, difference in FEV1 comparing biologic agents versus control group. So if you see, everything is favors treatment. So there is improvement in lung function also happens. Okay. Now, what about the mean change difference in asthma quality life comparing the biologic agent versus control? So they compared the quality life, and if you see this line, all favors control, favors treatment. So this is favors treatment. So your quality life also improves when you are treating. So this is a combined biologics, all biologics they are shown. And steroids is concerned, oral corticosteroid reduction to dose less than 5%, less than 5 milligram per day, prednisolone risk ratio comparing the biologics agent and with controlled series. So you will find that there is a significant amount of benefit favors treatment. Mean change difference of the oral corticosteroid reduction percentage comparing the biologic agent versus treatment. So that also favors the, you can say that the favors the treatment group. So overall, all the biologics have done very well over here. And there is a second meta-analysis. So just this is a one meta-analysis. This is called network study, December 22, Annals of Allergy and Immunology, it is published. What it shows that they also included as per their guidelines, criteria, 63 trials they included in the study. I don't want to go into depth, but what the lines are very important. Patient with eosinophil asthma, tezolizumab and dupilumab are the most effective in reducing the asthma exacerbation, improving lung function. Bendralizumab, dupilumab and mepolizumab probably reduce the use of oral corticosteroid more than 50% reduction in the oral corticosteroid dose. For the patient with eosinophilic asthma, more than 300 eosinophilic count, we found moderate to high certain evidence that bendralizumab, dupilumab, mepolizumab, racilizumab and omalizumab probably reduce the exacerbation compared with the placebo. Dupilumab and the tezolizumab can seem to be superior to other biologics. Mepolizumab, omalizumab and tezolizumab probably reduce the hospital admissions, and tezolizumab is reduced as the first biologic to reduce asthma exacerbation consistently and significantly in broad population of patient with asthma. The patient with low eosinophil count, this last line is important, low eosinophil count, biologics probably do not improve asthma control, asthma outcomes. For the patients, tezolizumab and dupilumab may improve the lung function. So this is something which is important to know, that how the biologics have coming for treatment of asthma, and this is how the current conclusion is that of the your meta-analysis. So this is the, just want to go fast about the various biologics. Omalizumab, which is very often used in allergic type of asthma, younger population with Ig levels are favorable between 30 to 700. They have best effective with evidence of rhinitis or sinusitis, and if you have skin testing is done, or if you have allergen test which is there. So classical allergic asthma, beautiful reduces the overall Ig levels, free Ig levels. So binds to free Ig and decreasing the cell bound Ig levels. This is how omalizumab works, and this is the age group, and this is the level which just discussed just now. So which patient will use the omalizumab? So this is a group of patients which will use omalizumab. Okay, it is not so very easy. I don't want to go the outcome of this every study, but because we have just discussed the meta-analysis, so I will skip this slide for the time being so that we have little more discussion. Anti-IL-5, mepolizumab and racilizumab, both MAPs binds the inhibits the IL-5, preventing IL-5 from binding its receptors on eosinophils and reducing the downstream of eosinophilic inflammation. This is the mechanism, and this is how mepolizumab works. And this is same way the indications are. We have already seen that here mepolizumab biomarkers is eosinophil, and this is the group of patients which we generally take. I just gone. This is how the various trials. I don't want to go, but you just see the graph which showing the effectivity of on changing the baseline glucocorticoid dose, exacerbation, and asthma questionnaire score. Okay. Racilizumab is another anti-IL-5, and here same where it is like a mepolizumab, and this is how the, but here age is 18 and older, severe eosinophil count there is less than or more than 300, it should be more than 400, and only biologics delivered intravenously. This is very important to know. And the dose is 3 milligram per kilogram body weight every 4 weekly. The weight-based dosing may offer a distinct advantage over the fixed dosing. So that's a very important over here. So if the low dose people will require a lower this thing, but age has to be above 18. And I don't want to go to the trials, but this all shows that there is a significant improvement in the overall in the lung function also and exacerbations also. Anti-IL-5 receptor benralizumab, this is something similar to mepolizumab, but there this is anti-IL-5 receptor. These receptors are there on eosinophils, okay, and these eosinophils, this biologics attached to that receptors, preventing the cascade mechanism of inflammation to happen, and that leads to destruction of eosinophil very rapidly. Okay, so there is a total destruction of eosinophil count, and you will find that the eosinophil count coming to almost zero in almost 24 to 48 hours time. So this is how the benralizumab works. So it acts not only on IL-5, but it is also on tissues, eosinophils also. So there is no head-to-head trial between the IL-5 mepolizumab versus benralizumab. Each has got advantage, disadvantage little. There sometimes a patient with benralizumab, if not working, you can't go back to mepolizumab. But if patient is not responding to mepolizumab, can be tried benralizumab. So there are some when you can shift biologics, etc. There are some data on that, but it is not great data. So we consider mepolizumab and benralizumab today to more or less similar. We have to select as per the patient's need and requirement, the cost and insurance, which is good for the patient. So this is how the natural killer cell destroys the eosinophil completely. This is a little different mechanism than mepolizumab. Okay. So indication is here is more than 12, dose 30 milligram every monthly for 3 injections, then every 2 monthly. And these are our trials. I don't want to go into that, showing benefit in exacerbation. And most important is corticosteroid requirement dose comes down. This is very interesting biologics, dupilumab, okay, full human monoclonal antibodies, inhibits the signaling both interleukin 4 and interleukin 13, binding to interleukin 4R alpha, which they share, okay. And the dose is here the biomarkers, again eosinophil count more than 150 and less than 1500. Dose is, see here, dose is more than 150 and less than 1500 for benralizumab, and this is higher level of eosinophilia dose has not been used. So mentioned. So we can use mepolizumab and benralizumab for hypereosinophilic syndrome. This is a US FDA approval indication. Okay. So we have recently treated at least 2 patients of hypereosinophilic syndrome with anti-IL-5, and fantastic results you can get. Okay. So this is about this thing. And the dose here is 400 to 200. This is all the dose which we already discussed. And this is the efficacy, the Venture trial showing the efficacy of anti-IL, and basically also significantly. I just want to tell about the next biologic is tezepelumab. Here it is at anti-TSLP level, and this is something which can bind specifically to TSLP, thymic stromal lipoprotein, blocking from interacting with the heterodiametric receptor. So whole chain reaction stops. Okay, so that is an advantage of this, and it reduces both the markers will be. Tezepelumab rapidly reduces FeNO. It also reduces eosinophil count. Rapidly reduces eosinophil count. Less than 300 in per baseline rate was reducing up to by 41%, and route is subcutaneous, and the dose is around 210 milligram. Okay, so this is something which is the outcome of that, serious adverse effects were not much. The effectivity is really good. So this is something which is something we are going to watch. So now, how will you choose biologics? That's a question which you will be asking. So many drugs which have got similar thing. Okay. So in difficult asthma clinic, a specialist who is managing asthma is basically the person who can guide you, because he is most well-read and most experienced, till a new markers come where anybody can say that, yeah, this is a marker, they don't have to refer to anybody else. Yes, with some experience of bronchial asthma management, one can say currently there will be some issues. So you have to take help of your colleagues who are experienced and who are practicing predominantly difficult asthma. Okay. Here choosing biologics therapy, what you are doing, good history. Okay. Age, number of exacerbation in past years, status of respect to oral glucocorticoid use, biomarkers, which are correctly you have to find out the real eosinophil count, FeNO level, serum total Ig levels, lung function, okay, and asthma control and other quality life. These all basically needs to be assessed. Okay, obviously, as Dr. Jay has told you, that diagnosis of asthma has to be confirmed. Number one, that's the first thing. Okay, and if it is comorbidities, has to be found out. Phenotyping has to be done. Okay, and most important thing is that if you have adherence and the correct technique is done, so you have to be convinced. So today, a patient comes to me for a difficult asthma. I would like to wait for at least 6 months, changing thinking, confirming diagnosis, comorbidities identification, treating comorbidities, treating asthma correct dosages, adding drugs, and seeing the control over next 6 months. And if I find, yeah, he requires steroids, that is the time. Or somebody, good respiratory physician who has diagnosed asthma, who treated correctly, and he has done everything. Despite of that, patient comes to you for what to be done, or he has suggested a biologic. Yes, now you don't have to wait 6 more months. The proper doctor has taken care of your patient, and then it comes to you. Yes, after going through the history, then there is no need to further wait for 6 months. You can reconsider. But before you consider the biologics, you should optimize the patient. So this is important line I would like to say. And then criteria for choosing biologics, again, I told you, the biomarkers are important, age is important, because certain biologics are not for less than 6 years, you have not seen, yes, and certain biologics are not more than less than 12 years. So every biologic studies have been done in different age groups. So age group biomarker comorbidities like atopic dermatitis and nasal polyposis is used as a important comorbidities, because benefits will be there in particular biologics. Dosing frequency is very important. Very high body weight, and if your Ig levels are also high, his requirement of Ig, anti-Ig will be very high. So you have to be very careful about that. Routine administration, subcutaneous versus intravenously. Intravenous, only one drug is there where it is dose related. So that is an advantage there. Whether the drug administration requires monitoring by healthcare personnel or not, that's also very important. You can reduce the cost. Today, some biologic patient can take their own, like how they take insulin. Okay, insulin daily is taken, they have to take every 2 monthly. So this is something which is important. Insurance coverage, there is an insurance coverage for asthma. Remember, for biologics, a lot of our government CDs, corporates are using this as a routinely for asthma care. Even insurance can be managed, okay, properly. Cost is important. What your patient is using, how we can reduce the cost, and patient's preference. You have to give a preference when the similar biologics are there. So this is how the assessment is done, which I already discussed. This is how the evaluation of comorbidities is done, various other comorbidities. And third, then patient factors shared to decision making. So these three important part which has to be there before selecting biologics: assessing the biomarkers, evaluating the comorbidities, and patient's factors shared to decision making. The patient is also important in the decision making. Obviously, before everything, you have treated your asthma, diagnosed the asthma correctly. So choosing biologicals, I don't want to go into the depth. I just this is just have to follow the flow chart. Asthma, this is very difficult to read also for you, but I would like to tell you the same protocol. Okay, finding out the asthma diagnosis, modifying the therapy, optimizing the patient, adherence, techniques, comorbidities and assessment, treatment of comorbidities like rhinosinusitis is being taken care, reflux has been taken care, obesity been answered, and other aspects been taken care, and then you come to biomarkers, and then as per the biomarker, as per the we select the biologics here. I don't want to go into the depth of it. Just you have to understood this key. There is a beautiful flow chart which has been given. Follow the flow chart, you will be able to understand. Once you start biologics, some patients are super responder. Okay, this is very important. Why they are super responder, we don't know. But super responders are they are defined by the group of patients with more rapid response to certain treatment leading to better asthma control and quality life. Very rapidly, in 1 or 2 injections, 3 injections, they become so good. They improve their lung functions also. The super responders rate is around 14 to 44%. That's very much. Okay, higher the eosinophil count, super responders. Okay, steroid response, if is in the beginning, is very good. These patients sometimes super respond, but you have to go and find out which is your super responder. So these are some commonly observed patients: male, smoking, no smoking history, lower BMI, higher T2 biomarker level, and later the age disease onset. So these are the super responder. Reasons we don't know. Switching and combining biologics. This is another thought which is switching biologic. Yes, we have treated omalizumab going to benralizumab and mepolizumab, and I have currently a patient under me where anti-IL-5 not really worked at all, and omalizumab last 2 years, no exacerbation, nothing, absolutely fine. Patient takes every 15 days injection of omalizumab. So 2 years they are doing it. So this is also possible. It's not that benralizumab and mepolizumab is better than omalizumab. No, which patient will respond to what, we can't tell. You have to observe the patient and take a. So switching also is possible of benralizumab, this thing, and there are studies on that. When switching happens, there is a good response being same. Okay, so switching is there. Combining the biologics has got no data much. So omalizumab with benralizumab together is not possible, at least not great data. Limitations of biologics. Okay, are there any limitations? Yes, we have a data for omalizumab for almost more than 20 years, but we have around more than 5-7 years data on benralizumab. But long-term safety, we don't know. The cost overall, once you started, we have to continue. Remember, 6 to 8 months, we have to give a trial to see they are responding or not. If they respond, we have to continue the medications. Okay. And if they don't respond, then we reassess the patient and switch the patient to other biologics, take opinion of your consultant who are more experienced, and take a decision about shifting or stopping biologics completely also. That also a decision which we have to make. Some do not respond to biologics, develop resistant to biologics. This is another thing, developing resistant to biologics afterwards. That is also possible. Can biologics be used in early asthma? This is a question which is there in the mind. Okay, not why we should wait for stage 5. Can we use it? No answer yet. There are no studies. Role of biologics in T2 low asthma and ABPA, which is much more common. The data is there is data coming on ABPA, but no studies or this is available. Our experience is that yes, it works in ABPA also. Future aspects of biologics, there is an urgent need for an evaluation of predictive correct biomarker. Head-to-head studies are required. Risk of immunogenicity and should be known. Development of neutralizing antibodies, that aspect we don't know. Markers for response to in patient with biologic, that also not available. Which are the markers where we say that they are responding very well besides the clinical data? More data are needed on the efficacy and safety of biologic therapy in special population like children and adolescents. In meta-analysis, there were hardly any side effects. Where some of the studies showed the placebo as the control group has more side effects than this. Okay. And biologics for type 2 low or severe asthma, this is also, we need a more data. Summarizing, if you see that currently we are in the era of biologics and asthma, in biologics in everywhere biologics are coming. So asthma is no more. In fact, asthma is started biologics much earlier, and now we are in the many biologics are likely to come. So we have to have knowledge about biologics. That's very important. So pathogenesis of bronchial asthma, etiopathogenesis of bronchial asthma, endotypes has to be understood by every test physician. They are infectious, but it is important to know that these agents are very effective, but for uncontrolled asthma, and these are all things. But more important is that understanding about asthma from inflammatory markers and phenotypic improvement to genotype helps in choosing the correct personalized therapy. So when you understand the mechanism of bronchial asthma, then we can use a personalized treatment to the patient with using a biologics. And it is important to know that the standard practice of asthma should be continued. It is not discontinued. Many times patient becomes so good with the biologics, they stop using inhaled steroids and inhaled bronchodilators. That's a thing which a lot of education is required. Mike, kuch taklif in why I should use my inhalers now? I'm quite all right. So this is a very common thing which we have seen in patients who are super responders. So that is a time you have to tell them that the baseline treatment has to be continued. So this is the statement, a line I can say that target roots more than symptoms makes asthma life healthy and happy. So with this, I think I would like to end, and Vijay and me are very happy to take your questions, and both from this audience as well as the doctors who are connected with the web. Thank you.
Excuse me, sir. So thank you so much. It was a really superb session. I just wanted to ask you one thing. Why allergen-specific IgE is required before we consider biologics? Total IgE and allergen-specific IgE.
So basically, we have Ig levels are required, okay, and if you are using your omalizumab, okay, then we have to confidently say that this is allergic bronchial asthma, okay. So allergen specific as allergies, which was RAS test we used to say, okay, is not to be that considered as a must requirement for treatment of asthma using omalizumab. Even if you have a strong feeling that this is allergic asthma, then you can use it. Yes, earlier we used to do RAS test, and also we used to do skin prick test to document this is a type of allergic asthma. Jay, would like to add anything?
The only thing is, so if you are using the anti-IL-5, you don't really need these tests. But if you're looking at anti-IgE, then generally it is one particular allergen which is driving that atopic asthma. And so you need to get that documented before using a drug like omalizumab, because you could have a non-specific rise in Ig even with eosinophilic asthma, in which case omalizumab may or may not help that much. But if you have a specific allergen which is triggering it, then your responsiveness with omalizumab is likely to be higher.
Can you give one more mic?
Sir, what is the cost of this biologics, and which is the right time to give biologics? I mean, if somebody is in exacerbation, so what is the day that we should give the biologics?
So the cost of your specific cost, now the cost depend upon the, for example, for omalizumab, the cost has really come down now, okay, but still it depends upon the amount dose of omalizumab you use, and dose is calculated as per the body weight, okay, and also Ig levels. Suppose your Ig levels is 1000, actually it is 30 to 700 is an ideal range, but suppose your Ig levels are 1000 and body weight is more than 100, so it becomes twice a day and dose becomes very high, okay. So still it comes to around 15,000 per month approximately. Yes, 15,000 to 20,000 rupees, still it is high, okay. And if you see the benralizumab, okay, or omeprazumab, the cost is approximately how they calculate, I'll tell you, it comes to around 2.5 lakhs rupees per year per 6 months. 6 months. So because 30 milligrams subcutaneously monthly for 3 injections, then 200, then every 2 monthly. So 3 injections plus 2 injections, that is 5 injections, will cost you approximately 2.3 to 2.5 lakhs. Okay.
Now, insurance companies, some of the insurance company cover up that. Okay. And, but still it will be like that.
And the timing you were asking, so with omalizumab, they have given a thing that you should not use in exacerbations. But with benralizumab, that is not the. In fact, there is a recent paper which they presented at ERS. It will probably be published where they have used benralizumab and compared it with steroids for treatment of exacerbation, and they found that it did equally well. So anti-IL-5 probably you can use start even while a patient is exacerbating, but if you're using omalizumab, you should wait for patient to stabilize before starting.
Monitor anything while giving the injection or after that?
Omalizumab has a little anaphylactic reactions happening, being reported. So this patient has to be observed. Okay, we don't give at patient's home, so we always keep the patient in the casualty. Or if you have asthma clinic, if you have facilities for monitoring the allergic reactions over there, uh, benralizumab and mepolizumab, no hardly any allergic reactions are noticed. So they can be given even at home also. Okay, so that is one. So these are the things. But for omalizumab, for first time, if you are going to give, I will certainly keep in the patient in the casualty, or at least for observation.
First dose, I think for all they usually give it in the hospital, but for mepolizumab and benralizumab, the companies themselves are arranging nurses to go home and give it to the patient free of cost. So patient doesn't even need to travel then.
Hello. This is Dr. Milind Sade from Indore. Am I audible?
Yes, yes.
I have got a question for Dr. Prabhu Desai. Along with the biologics, can we hope that the inhalational corticosteroid, beta 2 agonist, and other forms of therapy can be reduced or totally stopped only by using biologics?
No, we should not stop at all. We should continue the treatment of bronchial asthma, inhaled corticosteroids. You may reduce the higher dose of inhaled steroids to a moderate dose of inhaled steroid. And how your other asthma management you do, same way you continue. But completely stopping of inhaled steroids is not recommended and you should not do. Okay, so that this is the most important thing we have to tell to the patients also. Not to stop, reduce the inhaled steroids. And the doctors who are respiratory physicians, when they are monitoring the patient, say if they are using higher dose of inhaled steroids, we can try to reduce inhaled steroid, but maintenance dose has to be continued.
Okay.
So, any questions? Then we will ask Jay and his experience in handling the some of the diagnostic problems in asthma. Ki, what about the how a patient should undergo, because asthma presentations are many times very difficult. It's not that ki even respiratory physician can miss an asthma when it coming for the first time, especially the psychological aspects of this thing, and they have inspiratory wheeze or expiratory wheeze also can be manifested during the hyperventilation state when they are having, or some of the patient who complains of tightness in the chest and at a working place and lung functions are normal. So how you basically diagnose these asthma which are not very common, uncommon presentation of.
So when patient comes with uncommon presentation, obviously, I mean, you have to look if there are any specific triggers which are leading to the symptoms. Like, if you mentioned occupation, so is the patient worse off at the workplace, which could be some exposure either, in the air, or if they're working with certain chemicals, etc. Or if they have pets at home, then maybe they are worse off during the weekends. And then when they go to work, they are feeling better. So that temporal association might help us to know. Second, if suppose clearly patient is in front of you, if saturation is normal and just there is hyperventilation, but chest is clear and they just complaining of breathlessness, there's no other thing. Maybe best thing is maybe just do a peak flow. If your peak flow is showing 450, 500, but the patient is still hyperventilating, very unlikely that such patient is going to have asthma. And then maybe you have to look at other causes, whether it is psychological or something.
Correct. I think very rightly pointed out, the simple peak flow meter still has a role to play in diagnosis and management of bronchial asthma, though it is not at all in COPD, but in asthma still have a role to play. I just would like to ask, how many of you use peak flow meter as a monitoring tool in asthma diagnosis as well as treatment and evaluating a patient? I think this question is to all the people who are attending there also. If your own experience, if you have, please share with us whether you have your experience about still the peak flow meter, which diagnoses variability, which is also important aspect of asthma. So we are almost stopped now bronchoprovocation test, right? Doing it in asthma. So the peak flow meter also does some sort of a variability response, etc., and all that. And if they triggered asthma, we can also measure a peak flow meter. So what is your experience also is very important to know about peak flow meter in asthma diagnosis treatment. Anybody from the audience, okay, they can please share with us. So it will be a very interesting discussion. They are all audible, na? What I am talking. Jay, do you use an peak flow meter routinely? Do you prescribe a peak flow meter to your patient?
So we use it basically during exacerbations in hospital, yes, to look at, patient is getting better or not. Not frequently prescribing it at home, especially if I know it is asthma, then no. If it is doubtful, then maybe I might say, keep a peak flow meter. Let us see over the week how things are before
Correct.
we really label you as asthma. Especially because when they come with you, maybe spirometry is normal. So you might not be able to tell.
One more important aspect is that we always talk about small airway disease in asthma, okay? Because the lung function tests are okay, they are showing obstructive airway disease. And when we are reporting spirometry, moderate obstruction, reversibility. So you treat the patient in asthma, and patient still asthma control test or quality life, they are still not very happy. So are you target or try to evaluate for small airway asthma and try to change your bronchodilators or corticosteroids or inhaler techniques with them?
So if suppose your routine inhalers, you come to optimal dose, but patient is still symptomatic, then maybe, doing lung volumes or CT might show air trapping or,
Or even the impulse oscillometry or
impulse oscillometry.
FOT.
So that those things might say persistent small airway obstruction, despite your upper airways being okay. Then you might think of going to, things like cyclosinide and beclomethasone
small
and formoterol, those ultrafine particles which we have,
correct,
which might reach the smaller airways, and that can be more helpful
Right.
in these patients.
Right. Okay. Anybody uses small airway disease specific medication, change that line of therapy, or whether use impulse routinely in management of asthma along with spirometry?
Well, we use a peak flow meter, not for small airway disease, but for diagnosis of asthma in some patients who are not clinically, whose asthma cannot be diagnosed clinically, and patients is complaints of shortness of breath or difficulty in breathing. In that scenario, we have to use peak flow meter. Second is to educate patient that he should get an objective evidence when he gets asthma or asthma-like symptoms. So if you get objective evidence of reduced peak flow rate, then he can come for treatment. So for this purpose also we use peak flow meter.
I'm Dr. Yuvraj Bade from Pune. Actually, we use this peak flow meter regularly I have patients from age 6 years, and they are diagnosed with asthma. And the not only for the diagnosis of this asthma, but for the monitoring of this bronchial asthma, whether and it has a beautiful response that the patients they do that peak flow PFR morning at 8 a.m., 4 p.m. and they keep a record of that, and when they are they come for the follow up, they show me that our PFR, this was the initial PFR, and now this is the improvement in PFR. If something change happens into that PFR, they come in between before the scheduled time of consultation. So this peak flow, this peak flow meter, that has a very good in monitoring the bronchial asthma also. So I think we should use that peak flow meter regularly, not only for the diagnosis, but for monitoring of the asthma also.
I agree with you completely. In fact, we consider it's a like a blood pressure machine for hypertension, peak flow meter for asthma.
I
So they
tell
can measure the BP at home, here a peak flow meter. It gives you a lot of idea. It gives you sometimes psychological aspects of asthma also, at stress related asthma also, whether actually there is a bronchospasm is there or not.
I tell them that I start the antihypertensive drugs, and every time you come here, I check your blood pressure. It's like that monitoring of PFR is like a checking of blood pressure in bronchial asthma. So they accept it and they see that yes, my PFR is 300 and now it is 280 and three approaching to 300. That my asthma is well controlled, and they satisfy with the treatment and they continue that. They
Yeah.
continue that.
How many, they're all respiratory physicians over there. How many of you have access to Fino? Can you just raise your hand? I can see all of you.
I do Fino once in a month, twice in a month. So that is also helpful. We see that the Fino ranges, and we show that yes, you need the ICS treatment for your illness. So that is also helpful. We do spirometry, we do Fino also.
Jay, you are Fino Hinduja, long time Hinduja is using Fino. What is your experience in Fino, and how best it can be used in management of asthma?
I think mostly, I mean, if there's obvious airflow obstruction, then I don't use it that often.
Yeah.
But very often, those people who come with this persistent cough and spirometry is normal, very often the pheno can guide whether, maybe just ICS might help. Or sometimes even an asthmatic, you do a PFT is normal. But if the pheno is high, you can push up the ICS dose. So the dose of the ICS can be
Correct.
guided by pheno.
So
We don't have dupilumab yet.
yes.
So
Yeah, yeah.
that
So
can be
diagnosis of asthma, Fino may not have a great role, but maybe some coherent asthma, etc. You may. But a lot of data, I also don't have that much. Key, how many of you really differentiate viral tracheobronchitis from bronchial asthma? But yes, if the Fino is high, then you can monitor with Fino, and you can also check whether the patient is really compliant or not. Okay, that also one possible to do. So anybody in the here in Mumbai audience is using Fino or referring for Fino? No.
Sir, regarding the small airway disease, many times we do spirometry, but our FEV1, FVC, that do not support the obstructive disease. That it doesn't come FEV1 upon FVC less than what that 0.7. Many times it doesn't come. But this small airway disease, patient is symptomatic. They are wheezing, they are cough, nocturnal cough, breathlessness, chest tightness is there. Means clinically it's asthma, but it becomes difficult to tell them that yes, your spirometry report is normal, but you are having asthma. So that FEF 25, 75, at least we need to show them that you see these parameters are reduced and you may have small airway disease and continue these medications.
So yeah, correct. I think one aspect I would like to take today is the digital age. Okay, so is anybody? Are you here or the listeners? Are you using any digital technology for management or finding out asthma control or asthma exacerbations? Or does your patient comes with some digital scoring system where they can say that, ki, yeah, that, or do you think that it is useful or not at all? So anybody can answer because some apps are likely to come which are maybe useful for control of various diseases, asthma be one of them. Using any digital? No. Your patients? No.
Not really.
What about the asthma control test? Are we using it for a routinely?
I don't think I documented it every visit. It's, I
But-
think, more in trials and all that. But I mean, of course, you ask all the questions, but I mean, it will be a good habit to have the score.
5 questions
Yeah.
to be given in the OPD consulting room and
Yeah.
ask them to tick it.
Yeah.
Okay. So whether they are controlled or not. I think good idea, but we are being so busy and so many patients, and it's not just asthma clinic. We have tuberculosis patients. Sometimes they are COPD, ILD. So in India, we have most of the respiratory physicians are mixed practice. That's why. Okay. Then next comes to the treatment of bronchial asthma. Ki, Dr. Jay, I would like to ask you a question. If asthma is difficult, means this is a frequent exacerbation, etc., and you are not very sure, what is your choice? A dry powder inhaler is your choice, or a spacer is your choice? I mean, it's a very basic question. You believe in more dry powder inhaler, or you more on metered dose inhaler?
I think both are equivalent. I think I just look at what the patient is comfortable with.
Correct.
Most patients, if they are okay with a dry powder, like your Turbuhaler, etc., they have very good lung deposition. I would go with that. But some people would not be able to manage that. They might prefer a spacer. Definitely, direct MDI would avoid because most patients will struggle with the coordination for that. So either spacer or DPI, depending upon the patient's choice, we would depend.
Audience, anybody who are for DPI or can just raise hand if anybody is very more happy with dry powder inhaler and anyone is more happy with the spacer. I know if you can just raise your hand, I can have just an idea. DPI, how many of you are prefer DPI, dry powder inhaler? Okay, and spacer? Oh, okay, spacer. Okay. And nebulizers, only nebulizer. No, asthma is only nebulization. No, okay. So what is the maximum dose of inhaled steroid you use routinely?
Routinely maximum.
Obviously, now we are using a combination of formoterol and
So I would
budesonide.
say about either 400 twice a day of budesonide or max up to 250 to 500 of fluticasone. That's what we would go maximum, not beyond that.
Do you get any complications, side effects with this dose, whatever you're using standard?
Apart from local, I haven't seen much.
So how you manage local side effects?
So obviously if, spacer helps if you're using an MDI. Second is make sure that they gargle, because you could get oral candidiasis or thrush or, myopathy with hoarseness of voice. So gargling is very important. And especially, sometimes you have these singers who come to you with asthma. So in them, definitely, I think a spacer is better than even DPI or direct MDI.
Nowadays, everybody as a second hobby is singing,
Yeah.
with the karaoke.
Professional.
No, even professional to so,
Yeah.
but even people have got their
Yeah.
groups, they sing.
Yes.
So
There, I think with the spacer, there is least deposition in the oropharynx. So I think there maybe spacer might be preferable to using a DPI or a direct MDI or even nebulizer. So choice of device could depend on that, but keep insisting on inhalers and obviously do a throat check every time they come and check. You just at least look at it.
So besides local side effects, anybody has observed any systemic side effect because of inhaled steroid, not by oral steroid, inhaled steroid, which you are surprised or which you say that it's common?
Not really seen much.
Neural scene.
I mean,
Anybody?
with beta agonists, we do see
Yeah,
tremors and sometimes tachycardia, but I personally haven't seen with ICS.
Anybody in the audience want to comment on that? Yeah, we have some people who are in the advertisements and they are all, sometimes they are even a small pimple also they are worried about it. So whether is this a side effect of inhaled steroid as a question comes. So anybody want to comment anything about the other than oral side effects of corticosteroids, other
I
systemic.
think rarely, if you're, I think you on ART, some of the drugs they inhibit the metabolism of the steroids, including inhaled steroids. So there, the systemic side effects because it
Do happen.
might be there. So
So the more the intelligent patient and more the they are concerned about the overall health. Now they only people come out with the
more Google.
Google the side effect, and even once it is saying that edema feet is there. I was never having edema feet. So these are all my blurring has happened, and ophthalmologist says there is nothing but I am sure that I am getting blurring of vision. So these are all side effects. Patients do complain, and they are very difficult to answer because literature doesn't say that these are all the common side effects. And very tactfully, we have to deal with them, saying that continuing the medication, and this is another challenge which we face that in adults. But what about a lot of adult chest physician also treating pediatric patients, right? Yeah, doctor, you
Sir,
can comment.
just I want to, as you said right now, sir, that about side effects. See, patients smoke for years together. They smoke right and left. And when we start inhaler for a COPD patient or any ACOS patient, yeah, it's okay that they will have all the bad habits in the world. But when a doctor writes a inhaler, they will ask, ये क्या जिंदगी भर लेना पड़ेगा डॉक्टर? या मेरे को इसकी आदत हो जाएगी? So they don't want to means it's like they don't want to means quit smoking and all, but they will usually ask this question. And if a new patient he is diagnosed as bronchial asthma, and if you give an inhaler without counseling, that time he will either change the doctor or he will think that this doctor is not good because मेरे को तो ऐसा था ही नहीं. The patients who are means late onset asthma, some patients are having late onset asthma. So I really means I'm student of Prabhu Desai sir, as well as I can see Dr. Tushar Sahasrabudhe sir in the screen. So really counseling is very important for all the asthma as new patients as well as late onset symptoms. Thank you.
Correct. I think the most important is teaching our nurses or our attendants to asthma education to them, because we cannot spend huge time with them about education because the questions increase and increase and increase. So they require a second level of counseling at the level of nurses. So that's why asthma nurse or asthma educator in our clinic, somebody we have to teach them well. We are right, absolutely. I'm seeing last 25, 30 years, the pediatric asthma, okay? I can tell you that a large number of patients do come to respiratory physician. Everybody gets pediatric patient. The reason is that they feel that mother is having asthma, they bring, and they're all right. So they always bring their children also to you. So educating the children about taking inhaled steroids is a challenge, okay? So how you manage this? Obviously, do you treat some pediatric asthma also?
Yeah, rarely we do treat.
Okay.
The only good thing about pediatric is if it is well treated and controlled, very often the kids can outgrow the asthma and they might be able to stop. That's one place where you can tell the parents that not 100%, but 50% you might be able to stop your inhaler. But an adult onset asthma, you're probably going to need it lifelong. But in kids, if your 5-6-year-old comes with asthma and is well treated, maybe in 3-4 years you could be off treatment. But that's some kind of incentive you have to give the parent that if you don't treat it now, it's going to become chronic for life. So maybe that kind of some counseling we probably have to do it for.
Dr. Sahasrabudhe, are you there?
Mic is not working though.
Hello?
I'm there, but the mic.
Yes, Mr. Budhe, I would like to hear from you because you are a teacher, and about allergic rhinitis and asthma comorbidities. We know that asthma medications we give very regularly, but how you manage that sneezing aspect or allergic rhinitis when it is coexisting with asthma? Whether your idea about inhaled nasal steroids, and also regarding Montelukast, which is little more controversial, which is very good drug for allergic rhinitis.
No, I think allergic rhinitis has to be treated with asthma. Otherwise, the asthma doesn't get controlled. And I do prefer nasal corticosteroids. And Montelukast, I don't prefer that much. Levocetirizine works well. And mast cell stabilizers, ketotifen, I work quite a lot. and especially in children, and it's very safe for long-term use. So ketotifen I do use still. Chromoglycate we don't use nowadays. I think it's not available also, but
How
ketotifen.
frequently use you nasal steroid? How you step down, like we step down asthma, airways, so you step down the nasal steroid? How much long you use? These questions probably even I have got in my mind because everybody has got a little different this thing experience with the long term use of nasal steroids. So what do you think?
Mm, yes, I would like to switch to oral antihistaminics. Prolonged use more than 1 month is not really advisable.
Okay. Jay, do you have any different approach to allergic rhinitis, or you same Dr. Sahasrabudhe says he inhales steroids and
No, so I would
antihistamine.
say like maybe use the oral antihistaminics, and then as and when like if there's an exacerbation or increased symptoms, then maybe a week or two of inhaled steroids is what I would do.
Now, Montelukast is no doubt combination of levocetirizine, Montelukast, very I think most sellable drug in probably in India, and the controversies have there. So how you now deal with these controversies and the benefits of the drug?
Yeah, so there, I mean, neuropsychiatric symptoms, etc., have been reported with Montelukast. So if the patient is having good control with just antihistaminics and inhaled corticosteroids, I would stick to that. In case is not controlled with that, and you have made sure that there is no specific trigger, etc., you might add Montelukast, but you watch for any possible side effects like say sometimes headaches or insomnia and those kind of things. So you watch for that, and even in that it is about 5-10% who will get it, so 90% is going to tolerate it. And in those where it is tolerated, it's a pretty safe drug. So in those 90% we would probably continue it. It's only in that 5-10% you need to watch for, then probably have to withdraw it.
So very long term, we try to avoid, right? And then short term, say 6 months to 9 months, combine. So anybody in the audience has got any experience that there are side effects of Montelukast they have noticed? Uh, Please communicate with us so that just to know. Raise your hands. Ki, yeah, it is not a drug. We have seen side effects. Please.
Uh, I would like to comment. It is a safe drug, but in some children, especially nowadays, ADHD is increasing after the COVID pandemic, and some people they really get triggered off with Montelukast. So if we are treating for allergic rhinitis with asthma, we have to be careful, and especially the child is hyperactive. Try and stop it as early as possible.
Okay. Anybody else want to talk on that? Any seen any side effect? Yeah, I have seen a side effect of Montelukast like that. No. Okay.
Sir, from Bangalore, sir.
Yeah.
Sir, we have seen some patients who, in COPD patients, so they are chronic COPD patients, and then already they are in having some depression symptoms. They have taken Montelukast, say, for some 5 to 6 months uh, elsewhere. They have not consulted a doctor, but they have consulted a medical store, local medical store, and they have been taking. So some suicidal ideations were there. And when we consulted the psychiatrist told that this could be because of Montelukast chronic use without the prescription of a doctor.
Okay.
And one more was Montelukast with Bilastin combination, sir. That we would like to have a word from you, sir. Bilastin with Montelukast.
I think one thing is over-the-counter sale should definitely be stopped for Montelukast. It has to be with prescription under supervision. And like this patient with COPD took it where obviously there is no indication. And with Bilastin, I haven't used much. So, but I mean, I think there are issues about bioavailability of Bilastin. We know we need to take it on empty stomach. So there are multiple other issues going on with that. But they say Bilastin doesn't cause blood-brain barrier, is supposed to be safer. But there are issues with bioavailability, need to be taken on before meals, etc. So.
Yeah, you are right. And in fact, some controversies were also there regarding QTC prolongation with belastins, cardiac side effects, and all. So, see, it's very important to one thing I would like to, my experience, I would like to do. If you do not know that there are side effects, we feel everything is good. Okay. So this is not true. So having a knowledge about the side effects of medicine is very important. Most of the problems are because of the medicine. We have to accept it, which includes not only the metabolic problems, the hematological problems, even the electrolyte imbalance, and even the for ILD, so drug-induced interstitial lung disease is a huge thing. Unless we are all focused about that side effects are there, and otherwise we will not be able to pick up side effects. I'm very sure that you need a little more sensitivity to our medication side effects. So this is a message I would like to give you. Whether you are using any drugs, we have to be wise enough to understand the side effects. And doctor has really pointed out the Bilastine. We don't know really what exactly the side, because so many combinations are there. See, our average prescription of a patient in elderly patient with diabetes, hypertension, and COPD is goes to almost 15 to 20 drugs. We don't, what is happening inside, we don't know. How the patient take together, or whether they are having interaction with each other is something which is questionable. I don't know, the similar prescription is there abroad also, or whether it is there in India only. So I've seen
India is, I think polypharmacy is much more here.
much more. So anything else after this, we will come to a severe asthma. What is your experience, the great gathering which is there all over India, the hetero people and as group has created? I would like to ask you, just tell me the percentage of severe asthma as Jay has documented, ki after doing ruling out that, then only we should say severe asthma is there in our country, you feel. Is it really 5% or it's more than 5%? Or it's more than 10% or 5 to 10%. Shastra Buddhe, and you can also comment because
I think it's pretty low. It's less than 5%.
less
Most
than
studies can be very well managed. And if you follow a proper protocol for difficult to treat asthma,
yeah.
and rule out the comorbidities and the triggers, intrinsic triggers, extrinsic triggers, and they do very well on ICS LABA. Most of the patients don't require oral corticosteroids and therefore biologicals. The percentage is pretty low.
Less than 5%, you mean?
Yes.
Okay.
Sir,
Anybody
I,
have?
I have one question that most of our LABA and ICS, the combination is fluticasone and propionate. So is there any difference, means oral bioavailability or lung deposition of fluticasone propionate and as compared with the fluticasone furoate, so that the whatever that the asthma which is not controlled, that can be controlled with fluticasone furoate, which is not controlled with fluticasone propionate. Is there any difference between these two drugs, fluticasone propionate and fluticasone furoate?
I think bioequivalent, I think furoate requires a lower dose compared to propionate and might be okay even once a day. You might not even need to use it twice a day. So we have certain combinations like vilanterol and fluticasone furoate, which can be used once a day, and that might be good enough. So there are options there. And the dose also, I think, comes down to about 100 or 110 microgram compared to
50%.
yeah, 50% compared to propionate, which is almost 250 or 500 we need to use.
Yeah, you're right. And nowadays, propionates are hardly available now.
Sir, I have one observation. When I switch this to the vilanterol, my controlled asthma patients, they got uncontrolled. I don't know why.
See, your observation is correct. Anything which is controlled, we should not change. Okay. So if you try to change it, patient is not happy. Okay. And this is their own perception. This is very, very important.
What
And
happened by changing the drug to vilanterol?
yeah, yeah. So this is a one experience I would like to tell you that anything if you are giving, say for example, even combination of inhaled steroid and bronchodilator, you are using in a COPD patient, and he is absolutely fine. Imagine karo, उनको ना exacerbations and quality life is better. Now, why you want to stop that and change to some other inhaler? Dr. Sahasrabudhe, what is your take on that? Whether we should change as the guidelines say that inhaled steroid should be removed?
You are absolutely right. Actually, the winning team should never be changed. If the patient is controlled on a particular combination, please continue same. You can always step down and step up depending on the situation.
Correct.
But
Monitor the side effects.
exactly, no need to change.
you make the patient very unsettled.
Sir,
And
but the indications of using Vilanterol plus fluticasone, they are mentioning that when to use this combination. They are saying that you use this combination when your asthma is controlled with 2 times inhaled corticosteroids plus LABA, so that you can shift this 2 times combination to
Of it
uh,
is marketing.
ICS plus ultra LABA.
See, a lot of it is marketing, so don't always have to believe MRs. I think if you are happy with twice a day, your patient is happy, don't change. Sometimes the patient will come and tell you, I don't want twice a day. Can we shift to once a day?
Correct.
Then maybe you can go down to, instead of giving your salmeterol once a day, make it vilanterol once a day. That's different. That is if it's a patient preference. But if your patient is happy that I'm taking it twice a day and I'm happy, don't rock.
If patient is sitting at home, nothing doing, he will be uncomfortable in taking once a day. He would definitely like to have something in the evening. अरे रात का कुछ तो दो. That's a common. But the patient is extremely busy, working from morning 8 o'clock to night 12 o'clock. He will forget taking twice a day. He will like to have once a day. So all this is very interesting. So patient's involvement in any treatment, extremely important for our better compliance and reducing the side effect. Any question? Yeah.
Sir, as you mentioned about the side effects, as oral thrush is a very common side effect of high-dose inhaled corticosteroids. Uh, I found out one solution to this is cyclesonide being a pro drug has a very low incidence of having oral thrush. So if you really need high dose of corticosteroids and the patient is controlled but is suffering because of oral thrush, I think we can consider this as an option.
Correct. I think cyclosonide was available once a day, once at a time. I don't know. Is the stability of the part of the cyclosonide is a problem? That's why they are not using related to temperature or anything. Or pharma is not interested in cyclosonide. We don't know what exactly, but cyclosonide is a very good. Yeah, it's a good drug actually. Cyclosonide particle size is low, small area we manage once a day, no side effects. Oral thrush we hardly see. In COVID time we used to use cyclosonide, the inhaler.
It's
Any question?
it's a
Yeah,
pro
what
drug. That's why it
maximum
gets
dose
gets
of
converted into a steroid only when it reaches the bronchial epithelium, not in the throat. So the steroid side effect is minimized.
so what is the maximum dose of long-acting beta agonist inhaled, which we can use in a day?
So basically, you can use. I mean, ideally, if you say formoterol or salmeterol, formoterol is 12 micrograms up to twice a day, but you can use it as a reliever as well. So even up to 3-4 times a day, if you're having acute symptoms, it is safe generally. Of course, you won't want to use it at that dose for a very long time. But for 4-5 days, you can step up the dose to maybe 4 times a day as well, and then come down back to twice a day. Salmeterol, you would not want to go beyond twice a day because it has no role as a reliever. Then you will probably have to use a combination of salbutamol and beclomethasone or something like that for your reliever. But when you're using formoterol twice a day, you can go up to 3-4 times a day in case you have a mild exacerbation where you then don't need to use an oral corticosteroid. And after 5-6 days, you can come back down to twice a day.
We have around 5 minutes. So I would like to ask one important question. Once upon a time, theophylline we used to use in asthma and both COPD. COPD we almost stopped now. Asthma also almost gone from everywhere. But it's not that ki theophylline never control asthma in the past. Okay, we know that ki they used to come for aminophylline, boluses and drip also. I would like to ask ki still today, does the theophylline has any role to play in management of asthma? Asthma, not COPD.
Yeah, very minimal for maybe little additional symptom control, but not really specific, and definitely not in an exacerbation. I think the toxicity risks are much more with that.
Anybody else has differ?
Especially if you're using antibiotics, say macrolides or quinolones, with that the asthma, then it becomes even more. Sorry, your theophylline, it can be a lot more problem, especially in the elderly.
Cardiac side effects. Sometimes they are very haphazardly taken. Theophylline, morning, evening, they forget the dose, double dose. Okay.
क्या क्या
So,
काफी हुआ है बदनाम. But for a acute severe asthma, if the person is almost landing up on NIV, then as a last resort, I will definitely try theophylline. If that is going to
So-
prevent intubation, why not?
So there are people still use under controlled guideline, control ICU monitoring.
ICU when monitoring the levels,
Levels,
etc.
theophylline, intravenous, drip,
And a drip.
magnesium sulfate, and all those things they use. Any question?
Sir,
A
I
small
have a question,
question.
sir.
Any beta agonist not to be used in underlying cardiac comorbidities, postplasty, arrhythmias, or
I
anything?
think one is definitely avoid oral beta 2 agonists. You get people nowadays, even now we know GPs still give oral salbutamol tablets, etc. So please avoid that. That will have the highest cardiac toxicity. Also, formoterol is more likely to give you side effects like tremors or cardiac side effects. So in case you have that issue, then maybe salmeterol, which is a partial agonist, might be safer. So you might want to shift from formoterol to salmeterol.
Yeah, my experience, I'll tell you. My cardiologist in ICU will not allow me to continue the beta 2 agonist in the ICU. I don't know how much they are correct or how much I am wrong. But heart rate is high, cardiomyopathy is there, history of rhythm disturbances are there. Then it is sometimes very important to know that whether really your bronchodilator helping the patient or not. Okay, so
if it is in the ICU, then I would shift to short acting, where you can then skip a dose if needed or something and just continue the ICS.
But yes, it catches tachycardia, no doubt about it. Because in some of the bradycardias, where sinus bradycardia, heart rate going to 35, 40, those range, people use Astelin, salbutamol, nebulization, and it goes high. Okay, it's not that it doesn't cause. So it is causes tachycardia. We have to be very clear about the overall condition and use judicially the bronchodilators, not like almost in ICU, everybody is getting spasm, is nebulized bronchodilator is not correct practice. And we should try to, as a respiratory physician, we should be much more vigilant about that also.
Sir, can I ask a question, sir, from Bangalore?
Yeah, doctor from Bangalore, no?
Yes, sir.
Yeah.
Sir, any experience on using MgSO4 in COPD patients, sir?
MgSO4, we have not, magnesium sulfate. COPD, we have not used it actually. Asthma, yes, acute severe asthma, ascites asthmaticus patient, we have used it, but not in COPD.
Yeah, if a COPD patient gets arrhythmia, maybe not.
Yeah.
Okay, sir. Thank you.
And can I add one more point? It's regarding use of SABA in a asthmatic who is in the last trimester of pregnancy, because it has got a tocolytic effect.
Mm.
It is safer to stop LABA, I mean step down the patient in the 8th or the 9th month of pregnancy, because it can really cause a problem and a severe postpartum hemorrhage.
Okay.
This
Good.
is one point to be remembered.
Okay. So I think, can we end today's session? First of all, thank you for the extremely good gathering and interactions from all from Pune, Ahmedabad, Thane, Indore, Bangalore, and the audience who is sitting over here very patiently. And thank you very much, Dr. Jay, for being with me for discussion. And thank you, Hetero, for inviting us for this asthma symposium. Thank you very much.
Thank you. Thank you, sir.
Thank you, sir. Please accept our heartfelt gratitude for giving us this opportunity. Dr. Prabhu Desai, sir, and of course, Dr. Jai Munar Patan, sir, and all my delegates sitting over here. Not only here, all the 9 other venues. It's an extreme opportunity and honor for all of us that to have you on board today at different venues. And it was I'm sure you have enjoyed the interesting question and answer session. And always we are here to healthcare for such an program, question answer or scientific summit, to present to all of you. And in that juncture, I would like to say this is just the module 1 for this Pulmogard frontier of practices. But yes, another 3 modules are waiting, and we will be coming soon and connecting with you when and where, when to connect for another 3 modules. But yes, definitely would like to have you all again on the second module itself. Thank you. Thank you very much. Lunch is ready. I'll request all of you to go for lunch. Thank you. And another thing I'd like to share our heartfelt gratitude by a small token of appreciation. I'll request Silas sir to come and give the memento to Dr. Prabhu Desai sir. And I'll request Dr. Khandeparkar sir to come forward and give a small token of appreciation to Dr. Jayamular Patan sir. Thank you. With this, again, please go for lunch, have lunch, and thank you once again for being here and give us this opportunity. Thank you.